Dealing with breast cancers is also challenging at the moment because every year or every half years we have new markers, new information to provide into our reports, and the classification of breast cancers has also improved, but also it has become more complex. So at the same time, pathologists in labs, they have to increase the numbers of information we give in our reports, and are challenged by the numbers of cases they are dealing with on a daily basis. The exciting moment we are going through is that we have digitalization available in many departments. So it's very attractive and exciting to imagine working not anymore only on microscope, but also using digitalization and digital pathology. And what is also occurring at that precise moment is that a lot of researchers from academic university, academic world, and also companies are proposing all new tools based on artificial intelligence. So the combination of digitalization in one hand and the development of artificial intelligence tool creates a very enthusiastic period. I had the privilege of being proposed to participate into a validation study with Dr. Judith Sandbank from the Maccabi Health Service in Tel Aviv. And they offered us to participate into the validation of the Galen breast algorithm. This algorithm has been trained by Judith Sandbank and her team. More than 20 pathologists help her to educate the algorithm, annotating a large number of alteration, cancers, but not only cancers, benign lesions of the breast. More than 50 different types of lesions have been very well annotated and recognized by the algorithm. We decided to gather two series of cases, approximately 2/3 of the cases coming from Institut Curie, something like 260 cases, and the other cases came from Maccabi. We retrieved all the slides of breast biopsies balanced between invasive carcinomas, benign lesions, and in situ carcinomas, ductal carcinoma in situ. All the slides have been anonymized, scanned, and here it's also something very interesting with the study. At Curie, we scanned the slides on the Hamamatsu nanozoomer, and at Maccabi, the slides were scanned on the Philips ultra-fast scanner. So two different scanners, but also two different stainings. The famous HES with the saffron in the French stainings of slides. And at Maccabi, the H and E slides were anonymized and scanned. So the Galen breast worked on the slides. And in the other hand, the pathologist from Maccabi and the pathologist from Curie, three of us in each site, we reviewed the slides. The majority of the reviews were concordant with the initial diagnosis, of course. But for the discordant cases, we went into a process of reviewing the cases, the two first pathologists together, and then if still the cases were remaining discordant, a third pathologist helped us to adjudicate the cases. And that's the way we define the ground truth. So once again, it was a very robust process. The results were impressive, really, because the algorithm recognized, first of all, invasive carcinomas among all the benign or in situ lesions that were in the series. So the performance of the algorithm was really high. The algorithm was also very good at recognizing in situ carcinoma. Among the benign, it sorted very, very well the in situ lesions. But more than that, among the invasive carcinomas, the algorithm has been able to recognize lobular carcinoma from ductal invasive carcinoma. And here, this is becoming more and more important because in lobular cancer patients have a different prognosis on the long term, but also on the front line of treatment will be different. Generally, the tumors with lobulars are larger, and medical oncologists would like to use neoadjuvant treatment. And in fact, lobulars do not answer well to neoadjuvant treatment. So it makes a very important difference. If an algorithm can sort ductal from lobulars, you're going to be more efficient in proposing the right management for the patient. The other point is that the algorithm was able to recognize DCIS nuclear grading in a very efficient way. It recognized very well high grade and intermediate grade in one hand from low grade and ADH in the other hands. And we all know that the importance of recognizing appropriately the nuclear grading of the DCIS, because it starts to become possible to offer different treatments for the patients. Another also interesting option with the algorithm is that it recognizes the presence of TILs among tumors. It will highlight in red the areas rich in TILs. And the cutoff that makes the heat map red is 30% of TILs. And this is very appropriate because, for example, in triple negative, a group of medical oncologists are starting to work to figure out if triple negative rich with more than 30% of TILs within the stroma maybe experience desescalation of treatments for these patients. So this is very appropriate that the algorithm can identify the TILs, and not only in invasive cancers, but also in situ cancers. And sometimes it can be difficult to recognize in situ lesions mixed with TILs, but the algorithm does it very well. I'm very lucky because in my department I had the chance to obtain the fundings to buy the LIMS, the scanners, and the good screens. Which come just after that is the perspective of using AI to help us in sorting our cases and being augmented pathologists. So I'm looking really forward to play and work, because the term play, I use it on purpose because it makes our specialty that can look a little bit old-fashioned, really modern and really appealing. Just remember that now the medical oncologists turn to be very interested with pathology because also of the possibility of using AI. It's so funny to see how attractive we look now with our big screens and digitalized images. So we are really living a fantastic moment, and it's a kind of revolution. It's not only a gadget. I think that it's the starting point of a new way of working in pathology lab. And so I'm very much looking to it, yeah.